Hey folks, Scott Weingart here, and this is an EMCrit We. Today on the We, a slight change of pace. We're not going to talk about a clinical topic. We're going to talk about compassion. Don't turn off the podcast. This is directly relevant to your practice. It's totally implementable on your next shift. It's going to make your patients care better. It's going to make your perceptions of your shifts better. It's something you really want to listen to. What had happened is one of the participants in the Unburnable Cohort 4, Faye, recommended a book called Compassionomics. Now, I guess I'd be remiss if I didn't take a second to mention Unburnable. Unburnable is the anti-burnout course I do with my coaching partner, Rob Orman. This will be the 5th iteration of it. We're about to start up again in September. The course is extraordinary, and I say that not based on my own biased opinion, but based on the participants that have gone through it, many of who have come in just miserable in their jobs in the emergency department, the critical care units, and they've gone out with an entire different vantage, an entire different vision of how they want to continue practicing medicine. And we've had numerous testimonials saying we were about to quit, and after this course, we are reinvigorated. We want to get back into the hospital and enjoy our clinical time there taking care of patients. So if that sounds intriguing, if you're in the midst of burnout or you just want to stave off it ever occurring in your clinical practice, then come to the course. Unburnablecourse.com, all one word. Unburnablecourse, all one word. .com, or just go to emcrit.org/stuff. So as I was mentioning, she mentioned this book, Compassionomics. I'm like, all right, you recommend a book, I'll go check it out. And then I saw the author, the lead author, Steve Trzeciak, was a colleague who I'd worked on with numerous sepsis initiatives. He was the clinician's clinician amongst the research community. And wow, he must have had a change of pace here. And you'll hear why Steve started researching compassion. But the book was fantastic. Just a wonderful read, well referenced. I mean, every single point backed up by research. And you'll hear about that today. So we're going to discuss compassion, but in a way that you can, in just a brief period of time, make a real difference in how you approach and interact with patients. So let's get right in. Who are you and what do you do?
My name's Steve Trzeciak. I'm the chair of the Department of Medicine at Cooper in Camden, New Jersey. That's Cooper University Healthcare, and also our medical school, which is Cooper Medical School, Rowan University. I'm a practicing intensivist as well, and a bit of a research nerd and author, and I'm happy to be here. So thanks for the invite.
Well, it's a great pleasure. And ordinarily, we'd be talking about an intensive care topic, but somehow we're talking about compassion, very different topic.
That's also an intensive care topic,
that's
right?
True. We could care intensively, right? But how'd that happen, Steve? How are we here talking about your book, Compassionomics?
Well, for the first 15 years or so of my career, I was studying resuscitation science, and everything was going as planned. I had no plans for any sort of change in trajectory. And we had some grants to do post-resuscitation research in cardiac arrest survivors and looking at what is the optimal oxygen level following resuscitation from cardiac arrest that would reduce the risk of permanent neurological disability. And now I study things like compassion, human connection, and hope. So the why behind it is a long story, and I'll condense it down into the fact that I thought that the work that we were doing in resuscitation mattered. And for the rest of my career, I wanted to be working on the things that I thought mattered the most. And what I saw around, so of course it was vitally important if you happen to be in that select population that was needing post-resuscitation care. But what I saw around me was an erosion of not just compassion and caring for each other, but an erosion of relationships that was occurring essentially at the same time as a spike in reported levels of burnout. And not just in healthcare, but just broadly in society. There were abundant data that empathy, for example, among college students was declining over time, over the past 2 decades, and the speed of the decline was accelerating. So it was broadly in society, and perhaps it was just spilling over into healthcare. But I thought that was probably the most pressing problem of our time through my lens of experience as a physician researcher. It was what I was seeing all around me, and The question is, could we actually study it in some way that's rigorous?
I love it. And it's concordant with my experience, having been a physician coach for 7 years or so now, especially after COVID. People have
For sure.
simultaneous increase in burnout and decrease in empathy. And the two, obviously, in my mind, are related, as your book extols quite strongly. But before we go deeper, I think we probably should define terms, because anytime you're
Sure.
talking about empathy and compassion, everyone has a slightly different definition. And coming from a philosophical background, defining terms is crucial. So in your book, if I remember correctly, compassion is really empathy in action. Does that sound right, Steve?
Yes. And the researcher's definition of compassion is this: it is an emotional response to another person's pain, suffering, or struggle involving an authentic desire to help. So it's different from empathy, a closely related term, of course, but empathy is the sensing and feeling and detecting and understanding component. But compassion goes beyond that because it involves taking action to whatever extent somebody's pain, suffering, or struggle can be reduced. And empathy is vitally important. I just want to be clear about that, because if you don't sense, detect, feel, understand, you'll miss 100% of the opportunities to respond to patients with compassion. So an easy way to remember it would be an equation: empathy plus action equals compassion. And just to show that these aren't just semantics, there are robust neuroscience data behind the distinction in terms. So using functional MRI brain scans, what that research shows is that when you bear witness to pain and suffering, so you have empathy, it activates the pain center of your brain, which is not unexpected, because we all know it's very uncomfortable to watch people suffer. But what the same modality shows is that when our mind is focused on finding ways to help alleviate a person's pain or suffering, to take action to help, it activates a distinctly different neural structure. So it's not the pain center of the brain. It's what neuroscience researchers call a reward center of the brain. Reward, like positive affect, positive emotion, feelings of affiliation. But we all know that experientially as well, because it's part of the reason why it feels good to help people.
Now, I'd say the first 2/3 of your book revolves around why compassion is so important, with not just touchy-feely words, real hard research on all the ways compassion helps. Helps the providers, helps the patients, helps the healthcare system. I don't want to spend too much time on that because I want people to read your book to get that. But maybe you could give us a short synopsis of all the ways that compassion really is beneficial to healthcare.
Sure. So I think an important first question is, for good health, does human connection matter? So even more broadly outside of healthcare, the Harvard study of adult development, which has been going on for more than 80 years, found that the best predictor of good health and longevity into our 80s isn't some biomarker. It's not our cholesterol, it's not our blood pressure, it's not our hemoglobin A1C or any of those things. It's the quality of our relationships. And the flip side of that is also true, that there are abundant data in the literature that loneliness kills. In fact, the risk of chronic loneliness itself is as potent of a predictor of early mortality as any one of these three things in isolation: obesity, alcoholism, or smoking. And so human connection, or the lack of it, matters for good health and longevity. But what's the data that there are impacts for patients in the clinical realm? And Dr. Maz, that's Anthony Mazzarelli, who's a practicing emergency physician, and in addition to being our co-president and CEO here at Cooper, we uncovered 100 different papers on clinical effects for patients. And really, just to summarize, there are 4 distinct buckets, so to speak. So the first one would be practical, in that, in terms of quality of care. What the research points to is that in healthcare environments where there is less caring, patients are less safe. And I don't mean to infer cause and effect from this, but where there is a very high level of depersonalization, which is a cornerstone of the burnout syndrome, numerous studies have shown that mistakes, major self-reported medical or surgical errors, are more likely to occur. One postulated mechanism that could be that if you don't care very much, you're not so meticulous about the care that you provide. And perhaps you've had that experience. I know I have, when I come across a colleague who might not care very much. But sticking with the practical is how patients take care of themselves. And so what the research shows, and this signal is very clear and consistent in the literature, is that when you care about patients, they're more likely to follow your treatment instructions, they're more likely to take their medicine, and they're less likely to be lost to follow-up and never come back. So now shifting from the practical to the physiological or the psychological, there are abundant data that there are physiological effects of human connection. I'll just talk about one, and that's a patient's experience of pain, painful experiences. And so you and I and everybody listening to your podcast knows that compassion can't eliminate pain. But what the research shows in the confines of an experiment with very rigorous measurement instruments, that the touch of a trusted other does reduce a person's experience of pain, at least to some extent that is measurable. Whether it's clinically meaningful or not could be debated, but it's been shown not only in laboratory studies, but also in patients undergoing physical therapy for low back pain, patients with abdominal pain related to irritable bowel syndrome, patients with migraine headaches in a headache clinic, and post-operative pain as well. And then lastly is the psychological, which may be intuitive to everybody, that compassion is a cornerstone of the therapeutic encounter with a psychologist or a psychiatrist or an emergency physician in the middle of the night when you present with your depression symptoms and need evaluation. And in that way, in the way specifically that in that context compassion matters, has been shown to move the needle on something called demoralization, which psychiatrists or psychologists would tell you is, or the way I understand it, is a person's depression about their depression, like the feeling like I'm never going to get out of this. So in that way, compassion can be a powerful restorer of hope. And what we tried to do with all this work is not show that compassion matters in meaningful ways, because everybody, I think, knows that. We all know it's a cornerstone of the art of medicine, so to speak, but our aim was to figure out, is it just in the art of medicine? Is it just the cherry on top of the sundae, or is it just a nice to have if you have enough time? But what we found is that it makes not just meaningful differences, but ones that are measurable as well.
And I can't find a better source than the first part of your book for that. It just goes through so beautifully. And I think anyone who is going to argue the opposite side of the case at that point just hasn't read the research, because I think it's fairly compelling. I want to talk about implementation, because I think people might grant that this is powerful and beneficial, but I don't have the time for it. I don't have the space in my incredibly crowded schedule. I already am seeing like 10x more patients than I should in emergency medicine or practice or intensive care. I can't do it. And your book would make an argument that that's not true. So why don't you tell us about the less than 60 seconds idea for compassion implementation?
Sure. So here was the most striking number that Dr. Maz and I came across in all of our research in Compassionomics and all of our work since then. And it's the number 56. So according to a study published in the Journal of General Internal Medicine, 56% of respondents, all physicians, said that they don't have time to treat patients with compassion. So it begs a question: how much time does it actually take? So there have been a number of studies on this, and I'll just tell you about one. From Johns Hopkins University, in a cohort of 210 patients, the vast majority of whom had breast cancer. They were survivors of breast cancer. And the primary outcome measure was anxiety. Now, if you've ever had cancer or someone close to you has had cancer, you know that that's a super important outcome measure. And so what they found in experimental design, comparing a information-only consultation from an oncologist to a consultation with just a little bit more, what they call the enhanced compassion intervention, what they found is that there was a reduction in patient anxiety with enhanced compassion that wasn't just a numerical difference, but one that was also statistically significant. So the question then is, what was the intervention? So it was this: I know this is a difficult time for you, and I want you to know that I'm here with you. So I want you to feel comfortable in stopping me if anything I say today is difficult to understand or just doesn't make sense. We are in this together, and we'll go through this together. And then at the end of the consultation, the oncologist again said, I want to emphasize again that I know this is difficult for you, and I will be with you each step along the way. So how long did that take? They measured it. It was on average 40 seconds. It was 40 seconds. So Could it take longer? Yeah, of course it could take longer. But if we want to be evidence-based about it, what's the minimum dose, so to speak, that could move the needle in a measurable way? And the research points to less than a minute. Now, some of my colleagues at Cooper, I got to tell you, they hate it when I talk about this. And the reason why, it's not why you think. It's actually, I love the insight. What they would tell me is there should be no time dimension at all. And I'm going to point to some other research in just a minute, because you can go through your day with brusque efficiency, letting everybody know how busy you are or how busy you think you are in your head, or you can treat people the way we would want to be treated ourselves, the way people ought to be treated, and treat them with compassion. And if anybody held a stopwatch to you, it would actually be exactly the same. Now, it might not be exactly the same because the research points to some increments of time that are non-zero. Okay, I just want to acknowledge that. But it does point to the fact that being too busy for compassion might, and so this is a sometimes statement, and I know that practices in an emergency department setting are often far less able to be controlled than in the ICU in which I practice in. So I'm not saying that there aren't time pressures in emergency medicine or critical care for that matter. That's wherever we're doing critical care. I'm not saying that there's not time pressures. But what I'm saying is what the research points to is that to some extent that matters. There could be an effect that is just in our head. And here, let me tell you why I believe that. So a study from the University of Pennsylvania, a collaboration between the Wharton School and the Department of Psychology, randomized, this was not in a healthcare environment. This is just ordinary people, probably college students. And they randomized them to 4 different uses of time. And then they measured their feelings of time affluence. And that was the term that they gave to it, which means I feel like I'm not under the gun. I have plenty of time. I'm not in a rush. So they randomized them to 4 different uses of time and then measured their sense of time affluence. And the 4 uses of time were getting an unexpected windfall of, quote, free time. 2, spending time on themselves, so some self-serving time. 3 was just wasting time. And the 4th one was spending time helping other people. And what they found is that the most potent effect on time affluence was actually investing your time in other people. So their conclusion was giving time gives you time, or at least it feels like you have more time when you're doing something that is meaningful in the service of others. And so I'm not suggesting that time constraints are all just in our head, but sometimes they are. I just share that. And I'd love to know what you think about that, because obviously you got a very busy practice as well. So what do you think?
Yeah, I'd go back first to your colleague's objection, and I object to their objection. I think I'm with you on this one. And the reason I say that is I'm sure there are some just naturally compassionate people that might just inject it into the course of their everyday interactions. But there's an easy way to conflate niceness with compassion. And I think compassion's a different thing. What you talked about in that first study, the intervention that was actually tacked on at the beginning and the end, there was something very particular to it, beyond just being nice and maybe even beyond just being caring. It was putting the physician or the caregiver on the same side as the patient, rather than a doctor-patient relationship as we typically think about it. Doctor on high and patient now receiving the wisdom. And now you could go through your entire day being very nice. I don't think you'd get all the benefits that are spoken about in your book, Steve. I think there's something very particular to compassion, really saying, I am here for you. You don't have to do it alone. That's very particular. And it opens up the next question, which is that the studies you've looked at have demonstrated that even if you don't have the innate skills of some of your colleagues, that you could still easily enact most of these compassionate practices with really beneficial effects. So talk to me about deep acting and compassion.
So I love this study. It was published in JAMA, but it's been like 20 years ago now. And so what they talk about is the intentionality of having to do whatever you need to do to get in the right frame of mind to serve that person who needs your help, even if they're yelling at you. And in this paper from JAMA from now many years ago, what they equate it to is and I don't have a background in the arts, I should tell you, so hopefully I won't get this too wrong, but method acting, Heath Ledger and as the Joker in Batman, or Daniel Day-Lewis, or they become their character. So they do the work to actually become their character where they can't even differentiate themselves from the character. So that's an example of deep acting versus surface acting, which is just faking it, right? So faking it is probably better than being a jerk, but only so much so, right? Deep acting is...
Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Where all of your emotions are real. It's just that you had to get there with intentionality, right? So at the end of your shift in the emergency department or the ICU, and you've got one more, you're like running on fumes, but there's a family meeting that a family needs to talk to you, and they're really in need. And so you have to get there, right? In order to do a good job of giving them and serving them in the way they need to be served. So here's the example, and Dr. Maz came up with this example, and I think it's a great one. At least some folks in your audience have had the experience of being parents. And when you're a parent, sometimes you come home and of little kids, that is. My kids are all older now, but when you have little kids, you come home at the end of a long day and you're completely fried, just wrung out, right? And your kid, they want it to be story time. And you don't necessarily really feel like it when you walk through the door because you've had a really stressful day. So what do? Do you just yell at them and tell them about all the hard stuff that you had to deal with that day? No, of course. You let it be story time, right? And you speak to them in soothing tones. You bring them up on your lap. You do all the things that kids are used to when it's story time. And so here is the question I would ask those of you who have had that experience as a parent or as a loved one for a small child. Is that faking? No, it's not faking. It's love. You just had to work to get there. You had to take a deep breath and flip a switch in your mind that's not faking. It's just, I have to get there somehow because they need me right now because they need it to be story time and daddy's home, right? So I think of that sometimes when I am trying to flip that switch in one more case at the end of a really long day, and it's not faking if you just with intentionality try to get there. And then you'll find that in the moment, all of your feelings are real. It's just that right before you met that last patient or last family of the day, you didn't really feel like it, but you just did it anyway.
Hey, future Weingart popping in here. So this study and others, they're super interesting because what they show is essentially, even if you're not typically compassionate at the time they did the study, even if you don't feel it, if you fake it and you have an intentionality to fake it, then the results were pretty much the same as people who were intrinsically compassionate or feeling compassionate at that moment. And I know the phrase fake it to make it. I don't really love that one. It has some connotations I don't like. I prefer, the one I coined is emulate to instantiate. If you pretend you're one of those compassionate people and you do it enough and you have that real desire to come across that way, then it's pretty much indiscernible from the people that are genuinely compassionate when observers are asked, how did that doctor come across? Now, they refer to this as emotional labor. I don't like that term. You'll hear shortly my substitute for that. But that's what, if you read any of the literature, they're talking about doing the emotional labor of putting yourself in the mind stance to be able to deliver compassion, even if you're not feeling it at the moment. And it's still remarkably effective. And as Steve has said, it doesn't take much time. You don't have to do this for any extended period of time, but the results on your patients will be dramatic. Maybe more germane to the burnout discussion, the results on you will be dramatic. And maybe that's the real thing that we could push this across. The patient benefits will all be there, but what really comes down to is you will be happier. All right, let's get back in. And I think this just contextualized a little what comes after. Absolutely. And I come at this from a slightly different viewpoint because I've been a meditator for the past 35 years. And part of the meditation practice is a practice called metta, which is just embodiment of loving kindness. And there's an exercise I do with my coaching clients called enacted metta, where for the course of a shift, they have to leave every single person they come in contact with, patient or colleague or staff, better for the encounter than they were prior to meeting up with you. And they're doing that for two reasons. One, it is an exercise. It builds a muscle. But we ask them at the end of that, how do you feel on that shift? And across the board, oh my God, it was the best shift I ever had. I feel fantastic. So that emotional labor, maybe that's the wrong word. Maybe it should be emotional exercise, because we know when you first start going to the gym and you lift, you don't like it so much, but there's some goal you have at the end of it. But then after a few months, you start to really enjoy it, even though it's still painful. And then at some point you get that workout high and you love it. I think this is very similar, that people, when you first start flexing those muscles, it feels like a little bit of work, but you feel wonderful. You feel wonderful in the course of that emotional exercise, but then you start realizing it has carryover effects to the rest of your shift, the rest of your day, and it becomes not much work at all.
Because it feels powerful.
Exactly.
And so what I have found in our 7 years or so of doing this work after I pivoted the research program is that when you become aware of the power, whether it's a study that convinces you with odds ratios and confidence intervals, or an N of 1 experience of a patient that you impacted, or by the way, let's be clear, it's compassion for everybody, including our colleagues who are having tough times and going through stuff or just having a bad day. It's our compassion for each other. And by the way, if we showed more compassion for each other, I think how we took care of families and patients and families would be just fine. I need to say that. But you feel like you're wielding something really powerful when you've had more reps, so to speak. To use your gym experience, you just feel it's more powerful, and it compounds.
Oh,
it
absolutely.
compounds.
You had said something earlier, Steve, that I want to come back to because I think it's really important. You had said that empathy actually activates the pain areas of the brain, and we can understand why. We have a real neurologic mirroring of our fellow person. It's what kept us safe in tribal activities. And then compassion activates the reward center. Now, you could see what's happened in a lot of healthcare is the empathy, I think, is intrinsically there in most practitioners. Why else would they go into medicine? There's more lucrative fields if you lack empathy. So the empathy's there, but if you keep getting pain as a result of it, it's a natural inclination to try to tamp that empathy down. But you're offering another path. If now that empathy comes up and it's acted upon with compassionate action and the reward centers hit, you found a second pathway to deal with what would be pain from a pure empathy without action. And all of a sudden, there's a path that doesn't involve tamping down and solidifying a barrier around that empathy. So compassion actually is not just a path to making everything around you better. It's, I think, a direct path to dealing with the component of burnout that comes from empathy being blocked, being tamped down in yourself.
So I love what you just said. And for me, it's where the science meets the personal, because after a lot of years of working in the practice that I have, we often meet people and their families on the worst day of their life, of course, right? And after a long time of doing that, I became very keenly aware that I had every symptom of burnout myself, every single one. And so the three cornerstones of burnout as originally described are depersonalization, which I already mentioned earlier, emotional exhaustion, which is obvious, and the third one is the feeling like you're not really making a difference. So I was batting 3 for 3 there. And that was when we started to do our work in Compassionomics. That's just our moniker for the science of compassion. And what I saw was evidence that compassion for others can be a powerful, beneficial therapy for the giver too. So not just the receiver, which was totally different from what I was taught in medical school. So I went to med school in the early 90s. I remember being taught, don't care too much, because too much caring, too much compassion burns you out. I was literally taught that. I can see it vividly right now if I want to. And I didn't think to challenge that dogma for 25 years, which is shocking to me. But what was I supposed to do? The conventional thinking was meditate more. There's nothing wrong with that. That's good. As you said, extremely effective. Go on more vacations. Yeah, for life-work balance, that's great. Go on nature hikes by yourself. Okay, fine. Put on your app, headphones, block out the world. Okay, for all of these things, to me, it was either going deeper inward or it was like escapism. But I thought that something had to fundamentally change at the point of care with patients for me. Right? Or I just wasn't buying it was going to be something else. Those things are good. They can be helpful. They're not unimportant. They're very important. But I thought something had to change in the point of care. And that's when we became aware of the evidence that 80% of the published literature shows that there is an association between compassion and burnout, but it's inverse. So if what I was taught in medical school was true, you'd see high compassion with high burnout and low compassion with low burnout. But 80% of the published evidence at the time was inverse, high compassion, low burnout, and low compassion, high burnout. So why? And if it's one thing that we've found in our 7+ years of studying this now, it's that it's this. This is the one thing. The key to resilience is relationships. Key to resilience is relationships. And so I did my N of 1 experiment with me being the only study subject. I decided I was going to care more, not less, connect more, not less. And I'm not just talking with patients and families in the ICU, but and not just with the nurses and not just with the trainees and not just with my colleagues here at Cooper, but even with my friends and even at home. And what I got was the deeper relationships that flowed from that. Because if you don't have the deeper relationships when you're at work, like all you have is a super stressful job. And so that was when the fog of burnout began to lift for me. It was because of relationships, but it was through more compassion, not less, not like withdrawing or clamping down, as you said. And there's a ton of evidence that, in fact, there'll soon be a second meta-analysis published. I was a reviewer on it that shows that there's been even more data to suggest that this is an inverse association. But you said one thing that I want to speak to clearly. You said about mirroring, right? Mirroring. So what the research, and there was a meta-analysis just published by Sarah Conrath and her group about this, that what I told you is true, high compassion, low burnout, low compassion, high burnout, except when you are mirroring, meaning you are taking on another person's pain, right? And so the way I think about it or frame it is vicariously experiencing another person's pain. In that case, there actually is a positive association with more caring and more burnout. And so there's a brilliant neuroscientist named Tanya Singer in Germany who has studied this, and specifically she's termed this self-other distinction. Self-other distinction. And what that would be is, and it's not a philosophical or a psychological thing. She studies this with brain imaging, very rigorous neuroscience. And what she's found that with self-other distinction, you can still lean in and do things for people that are meaningful and yet not vicariously experience their pain. So what does that look like in clinical practice? So I go to see a patient and it's a devastating tragedy. And I can enter that space and say to myself, this is a tragedy. Thankfully, it's not my tragedy. So what I'm going to do is find some little thing for this patient or for their families that maybe can't fix their problem, but is meaningful to them. And I'm going to focus on that. I'm going to do that. And then you get all the benefits of compassion, but you don't vicariously experience the other person's pain. And I know maybe if somebody's new to the field and still in training, that might seem like very nuanced differences. But for me, it's made a huge difference. It's made a huge difference.
No, I could not agree with you more. In fact, I've come to a similar realization, and I actually take it a step further. And when exposed to those tragedies and given our unique work choices, we are exposed to these tragedies all the time. I actually have a moment of flooding of gratitude. And these tragedies are just really a moment of how lucky I am that I'm not experiencing this horror. And then that naturally leads to a desire to enact compassion. How can I give back something in this situation, whether it be to the family members, to the patient themselves, to actually honor the moment of what's going on. That circle of the tragedy coming and not taking it in to yourself, not making it your pain and suffering, but instead just immediately giving back. It just changes the entire dynamic of the situation.
One of my favorite photos, and I say favorite, it's a very poignant moment, and so it's not a celebratory thing, but what crystallized the experience of the pandemic for many of us, it was a nurse in Texas, and the nurse was in an isolation room with a critically ill COVID patient and wrote on a piece of paper and held it up to the glass, and it said, I'm not coming out yet. Something, I'm paraphrasing, but it said, I'm just going to hold his hand a little longer. I don't think he has much time left. And to me, that was such a beautiful way of acknowledging the tragedy in your mind. You can't fix this person's problem, but holding their hand in the last moments of their life might be the most meaningful thing that anyone could do for somebody else, and the only meaningful thing that could be done for this person who was dying. It was the only thing that was left. In that way, they know they finished that shift completely wrung out, exhausted, and all those things, and knowing that they did something so meaningful for that person, even though they couldn't fix the problem.
I love it.
And there's something that I think is, we talk about compassion. What do you say? And sometimes you don't say anything at all. There was a pastor colleague of mine. He used to make a lot of sick calls in our hospital before he retired. And he used to make fun of us. And we would have banter back and forth. And he'd always say, what's wrong with you doctors? I'm like, what are you talking about? He says, you guys are always talking. In moments that are really heavy and there's this silence, you guys for some reason find it so uncomfortable that there's silence. You just yap, 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 yap. Sometimes the most powerful thing you can say to somebody isn't with any words at all, just letting them know through that they're not going to go through it alone. He used to say to me, I just like to sit with people in their suffering because that says more than anything I could say that comes out of my mouth. And so just being present for people. And I try to practice that. And I think it's helpful for the receiver, but for the giver too.
Is there anything else we need to add, Steve, or is that the point we should stop at?
First of all, you mentioned gratitude. We're like research nerds, right? So we always want to go back to the data. The data on gratitude is powerful, that an attitude of gratitude is good for you, but why? So there was a meta-analysis published a couple of years ago that gratitude primes your mind to see opportunities to help and serve other people around you. So I actually don't think, and for any gratitude gurus, don't come for me, okay? But I actually think the gratitude primes you to see opportunities to serve people. And when you're serving people, that's where you get the benefit. So it's like you need the gratitude to put you in that mindset, because then you see opportunities all around you. Like in everyday life, a University of Toronto study showed that in everyday life, so not healthcare, just regular people, regular day, 9 opportunities every day to treat people with compassion. And that scares me, because I'm like, how many did I already miss today? But being grateful, as you point out, it opens your eyes to those opportunities.
I'm sure that's true, Steve, but I think you're underestimating the additional benefits of gratitude. And what I'll tell
I knew you were going to say that.
Yeah, I have to, because my biggest insight into burnout is that burnout makes you start wearing a pair of glasses covered in poop. And you see the entire world through these poop-covered lenses, and then everything looks like crap. And what gratitude does is you start seeing all the goodness in the world. You start seeing all of the nice things, the beautiful things, the wonderful moments. And then that alone will start radically changing your perception of the world and how you go about it. And I'm sure it does, just as you say as well, offer a whole sharper vision of all the possibilities to enact compassion as well. But I think gratitude, even without it, has benefits.
I'm a believer. You
All right.
convinced me.
Anything else we need to add, Steve?
So our most recent work right now is studying. So our MO is we like to look at familiar things in unfamiliar ways. So rather than examining things that people call soft skills or things that are soft and squishy or whatever, we don't look at them through a philosophical or theological lens or a moral or ethical lens or emotional sentimental lens. We try to look at them through the lens of science. So our work right now that I'm the most excited about is we're actually studying the science of hope. Hope. And the researcher's definition of hope is a belief that the future will be better than today, right? So taking those glasses off for the burnout glasses that you said that you can't see through anymore. So it's a belief that the future will be better than the present, and we play a vital role in making it, meaning we have agency. So it's not just a wish that you or a feeling you wait for to wash over you. It's hope is actually something we do, and there's abundant evidence in not only in healthcare and recovery and longevity, but also in career and success and learning and kids going through school and sports. And hope is something that can be built. So I don't think about hope anymore in like a Pollyanna kind of way. I look at it in an evidence-based way because the evidence base is really robust. And so that's the next book, Scott. So as soon as it comes out, you can have me on again. And
I was going to say, as soon as Hopeology is published, we'll have you right back.
It's the Hope Effect. It's the Hope Effect. But yeah, I look forward to connecting you again, and we can spend some time talking about the signs of hope.
I love it. Can't thank you enough for coming on, Steve.
Pleasure is all mine, and very grateful for you, for your podcast, which has been on now for many, many years and impacted so many people who take care of people. And so we talked about gratitude, right? So I'm grateful for you. I know the field is grateful for you and your work. It's had a huge impact, and just wanted to make sure that we acknowledge that.
Thank you for that kindness, Steve.
Totally.
So there you go, folks. Go and get the book, read it, and then implement it in your practice. Teach it to the people around you. Make a difference. So easy, so quick, so potent. As I mentioned earlier, the cohort 5 of the Unburnable course now has tickets up for sale. And I would love, love, love you to join us for that course because it is so much fun. It is so practice changing. It is so life changing. We've spoken to some of the spouses of our participants, and they're like, oh, wow, this was the best money we ever spent. My life, the life of the spouse, is infinitely better, which just has to reflect how much better the life of that doc got. So come join us at the course, unburnablecourse.com, unburnablecourse.com. Scott Weingart for the EMCrit podcast saying bye-bye.